We have a wonderful speaker and a very interesting topic tonight for this series. Dr. Madabhushi, who is the director of the Laboratory for Computational Imaging and Bioinformatics in the Department of Biomedical Engineering at Rutgers University. Dr. Madabhushi received his bachelor's degree in biomedical engineering from Mumbai University in India, his master's in biomedical engineering from the University of Texas at Austin, and his PhD in bioengineering from the University of Pennsylvania. And he's, as I said, an assistant professor in the Department of Biomedical Engineering at Rutgers, where he's been since 2005. He's a senior IEEE member, a member of the Cancer Institute of New Jersey, and an adjunct assistant professor of radiology at the Robert Wood Johnson Medical Center. So he's not only involved in engineering, but he's also involved in medicine, which I think is really, really interesting. Now, note that Dr. Madabhushi received his PhD in 2004. He's published over 75 articles already. I don't know why he even agreed to come tonight, because he won't be able to finish another article today, but that's an absolutely amazing amount of productivity in leading international journals and peer-reviewed conferences, and patents pending in the areas of medical image analysis, computer-aided diagnosis, machine learning, and computer vision, and in applying these techniques for early detection and diagnosis of prostate, breast, and ovarian cancer from high-resolution MRI, MR spectroscopy, protein and gene expression studies, and digitized tissue histopathology. He will be speaking tonight, as you can see, about the computerized detection and diagnosis of cancer. So let's welcome Dr. Madabhushi.
Thank you very much. And hopefully my talk over the next hour or so will, I will, in my own way, try to make up for the fact that you're locked up inside and not enjoying the beautiful weather outside. So I'll try my best. And thank you very much for that very kind introduction. I wanted to keep it formal, so if at any point during my talk you had a question, please feel free to interject and ask me a question. So I'd like to keep it interactive. Like Barbara mentioned, I have a lab in the Biomedical Engineering Department at Rutgers University. That's the website for the lab, just in case anyone wanted to visit the website. There's a lot more information about what we do there. We're also getting with it, so we're on Twitter and YouTube, so you can check us out on both those sites. It is only fair that I acknowledge the true stars behind all the work that goes on in my lab, and as you just saw, I coolly take the credit for. But these guys, my graduate students and postdocs, are the real stars, and I just want to take a second here to acknowledge the significant amount of effort that they bring to all these wonderful things I'm going to be talking about. Also want to acknowledge my clinical collaborators, both clinical as well as industrial collaborators at the University of Pennsylvania, at the Cancer Institute of New Jersey, Boston Medical Center, the University of California, San Francisco, and the Beth Israel Deaconess Medical Center up in Harvard. We also have close collaborations just because of the nature of the work that we're involved in, cancer imaging. We work closely with some folks that are right here in Princeton, Siemens Corporate Research, just down the road on College Road East. And we also have collaborations with several other international universities as well as companies. So without further ado, I wanted to talk about the technologies that we're involved in with regards to early detection, diagnosis, prognosis, and diagnosis of cancer using imaging. And I'll talk about what those various terms mean as we proceed along in the talk. But just before we get into the technology that I'm involved in myself, I wanted to sort of throw out there some of the various different kinds of imaging data that now is being routinely acquired on a day-to-day basis. So what you're seeing here really is the emergence of imaging to not just look at structure, but to look at function, to characterize metabolic concentrations, to characterize protein and gene expression data. So we've evolved roughly in the last 50 years from going and looking simply at an X-ray of a bone to now being able to look dynamically at functional and metabolic processes in real time as they take place within the body. But with the profusion of medical imaging data that is now rapidly available to us and that we almost take for granted, the problem is one of data density. The problem is one of how do we get a clinician or a physician to be able to look at this tremendous amount of data and to be able to render diagnosis in a consistent and reproducible fashion, day in and day out. Just to give you an idea of the scale of the problem, as far as chest CT goes, chest CT, of course, is being routinely done for looking for lung cancers and lung nodules. The average size of an image in the XY plane, so just the 2D image itself, is about 512 pixels into 512 pixels. That's the amount of information that's on a single CT image. Now, if you put into perspective the fact that one typically does a volumetric scan, one would scan the entire chest, that's about between 64 slices to 512 slices. Now, that's just patient image data that's coming from one single scan. Now, that's the kind of data that a radiologist now needs to look through, 64 to 500 slices, 512 square in the XY plane, to be able to identify essentially a nodule or a lesion that may not be more than 10 or 20 pixels in diameter. Right? So that's just to give you an idea of the scale of the problem. So clearly, our issue is not that much with resolution. Our issue is not the fact that we are unable to procure imaging data in vivo. Our issue is one of volume. Our issue is one of having the tools, or rather lack of tools, quantitative tools, computerized tools, to be able to go in and do the data analysis in some sort of quantitative and reproducible fashion, in a way that complements the diagnosis that can be rendered by a doctor. So essentially, if I had to sublimate everything that we do into one term, that term would be CAD, or computer-aided diagnosis. And I hasten to add here, for any physicians in the audience, that the objective of computer-aided diagnosis is to complement what a physician does, to complement what a radiologist does, to complement what an oncologist does, not to obviate the oncologist, not to obviate the pathologist, not to obviate the radiologist. Okay? So that's my disclaimer up front. Okay? And this is true. I mean, I don't say this, just as simply for being gracious to my clinical colleagues, but it's a matter. It is a fact that there is only so much that a computer program, an artificial intelligence or a pattern recognition program can possibly do. Okay? At the end of the day, the high-level information, the domain expertise, can certainly not be reproduced in any short to medium time frame. Okay? We're hundreds and hundreds of years away from any technology that's going to be able to completely replace what a radiologist or a pathologist is going to be able to do. But what we can provide are technologies that can complement the physician, that can aid in diagnosis, that can speed up the diagnosis, so that a physician can come in and look at the data and render higher level diagnoses. Right? So just to sort of further emphasize the need for computer-aided diagnosis, and more specifically in the context of cancer, because my interest is in cancer imaging, these are statistics, these are dated statistics from about a decade ago. You can see that cancer mortality in the US was over 500,000. This is about 10 years ago, and that number has risen to about nearly 1 million fatalities every year. Okay? And that's an incredible number when you think about it. 1 million fatalities in 2010 on account of cancer. When you consider the population is about 300 million, that means 1 in 300 people in the United States every year dies on account of some cancer-related complication, right? So now that's not even considering the number of new incidences of cancer every year, which is much higher, okay? And that's probably a number that's more like 1 in 50 or 1 in 40 Americans that on a yearly basis is diagnosed with some sort of cancer. Okay? And these are alarming numbers. And again, the issue is not in our ability to image or acquire the imaging data. Our ability is really the bottleneck concerned with the quantitative diagnosis of this humongous amount of data. from so many people that's being routinely acquired, right? These are some slightly more recent statistics. That's just a breakdown of on sort of a per disease or per organ-based breakdown of the cancer-related deaths. And you can see that there's about an even split between men and women. In men, the second highest cancer-related cause of death is because of prostate cancer. In women, it's on account of breast cancer. Of course, lung cancer is still by far the most common fatal cancer in men. Right. So I went over some of the reasons that computer-aided diagnosis is important, but to further emphasize, the reason for doing CAD is not just diagnosis, but certainly in the context of predicting outcome of a patient. So every year we're able to identify the presence of cancer in several million men and women. Okay. The question, however, is what do we do once we know that these men and women have a particular kind of cancer? The next question, the big open question now, is how do we start to treat these people? What is their outcome going to be? Okay. Are they going to respond favorably to a particular treatment? What are our alternatives? So the role of computer-aided diagnosis is not simply in improving the early detection or diagnosis of the disease, but is much more in terms of predicting outcome and also directing therapy. One of the big issues in treating cancer is the fact that we need to be able to direct the therapy in an accurate and focused fashion. Just an example of why we need to do this in the context of prostate cancer. One of the major methods for treating prostate cancer is using radiation therapy. Now, not many people know that incorrect application of radiation or over-radiating the prostate is one of the reasons for bladder cancers. Okay? So here is the sweet irony of the situation, that in treating prostate cancer, one actually causes another kind of cancer. So the role of computer-aided diagnostic technology is critical not just in being able to detect early detection of the disease, but also in its ability to direct the treatment in a more focused fashion so that we minimize radiation damage to areas that are not invaded by disease. Okay? And of course, there are obviously other translational issues as well. So if we can use computer-aided diagnosis, for instance, to identify obviously benign lesions. So in the context of the breast, anything even remotely suspicious is immediately sent off for a biopsy. Okay? However, only 10% of lesions or tumors in women that are sent for biopsy turn out to be positive. Now, if you consider the fact that each biopsy costs about $5,000, you can consider the significant cost to the healthcare system. So could computer-aided diagnosis be now used to sieve out the very obviously benign lesions? Can we complement the doctor's diagnosis and say, no, I'm certain, if a doctor is 90% confident that something is benign, that doctor is still going to send that lesion for pathologic diagnosis, is still going to biopsy that lesion. However, if you had another expert, if you had a computer-aided diagnostic system that's looking at these images and rendering an automated diagnosis using an artificial intelligence algorithm, a pattern recognition algorithm, and says, hey, I also have a 90% certainty that this is obviously benign, now you're up to a much higher confidence level because you have two experts now suggesting the same thing with the same degree of confidence. So that's really where the role of computer-aided diagnosis is, to complement the doctor's primary opinion. Right? So certainly there are translational, huge translational and health implications in the use of this technology. And where can we apply this technology? Well, we could apply it certainly to all kinds of imaging modalities. I showed you some of those imaging modalities up front. These are some of the ones that we're more familiar with: MRI, CT, PET, ultrasound. Obviously, we could apply this across body regions. I talked about cancer, but certainly we could look at it in the context of cardiac-related diseases. We could look at it in the context of brain-related diseases, Alzheimer's and MS, and of course, prostate and breast cancer, colon cancer, and lung cancer. All right. So that's all well and good, and certainly computer-aided diagnosis has a huge role to play in complementing the doctor, in helping in rendering diagnosis. But I want to get back to what I started to talk about with using this technology to predict outcome. So there's a mantra going around that a lot of you might have heard of, which is the mantra of personalized medicine. Okay? And very often it gets thrown around without people perhaps really considering what that means. If I had to distill my sort of 20-year or 30-year career goal into one slide, it would be this slide. Right? So really what our interest is in defining quantitative signatures for disease to be able to predict the disease extent, that is rendering diagnosis, but also doing prognosis as well as diagnosis. Prognosis is the ability of predicting the outcome of someone who has a particular disease. So we know that patient has a disease. What is the long-term outcome of this patient going to be? Is this patient going to have a good outcome, favorable outcome to a particular therapy, or is this patient going to have a bad outcome? Diagnosis, on the other hand, is the ability of this computer-aided technology to be able to direct treatment. So I gave you the example with prostate where you want to be able to use this computer-aided imaging technology to be able to direct therapy in a more focused fashion so you minimize the radiation damage to extraneous areas, areas outside the prostate. Okay? But there is a role for non-imaging modalities in all of this as well. So we know, for instance, that there are signatures for disease that reside in data that's being acquired at multiple scales and multiple levels. Now, on a routine basis, certainly in the context of breast cancer, we're doing molecular subtyping of breast cancers. So any woman that gets a biopsy of a lesion is going to have histological assessment. So that tumor is going to be biopsied, that's going to be placed on a slide, it's going to be stained, and a pathologist is going to look at that slide under a microscope to identify the presence of disease. And having identified the presence of disease, is going to look at information that resides in the genes, maybe that resides in the proteins, and come up with a molecular profile, identify the molecular subtype of the lesion. So what that means is, we've got, in the context of breast cancer, a woman who goes, maybe gets an MRI done, gets a mammography done. So you've got an MRI, you've got a mammography, which a radiologist reads. You then do a biopsy if something appears to be suspicious on the MRI or the mammography. That biopsy specimen then gets placed on a glass slide that's looked at by a pathologist to render a diagnosis. And then that piece of tissue sample is going to be molecularly profiled for the information in the genes and perhaps the proteins to come up with a molecular classification of the lesion. So what we have here are signatures of the same disease that are coming from imaging, that are coming from the characteristics, the patterns in the tissue sample that's coming from the biopsy, and we have patterns that are coming from the gene expression profiles and potentially the protein expression profiles. So when we start to talk about personalized medicine, one of the things that we're really talking about is our ability to quantify and fuse these different signatures that reside at these different scales and in these different modalities. How do we take information that a radiologist is able to see in an MRI and fuse that information with the patterns that a pathologist is seeing on that tissue sample placed on that microscope? And how do we then fuse that information with the profiles of our gene expression or protein expression? So as we go forward, and this is my hypothesis, shared by a few other people, that the real way that we're going to address this issue of personalized medicine, or try to find a solution to tailoring therapeutic regimens for patients based on their specific disease profiles, is by really fusing, quantitatively fusing all this information that we're acquiring and that resides across multiple scales. And with that information is then going to help us to be able to predict outcome and decide on the appropriate therapeutic regimen for a specific patient. Right? All right. Now, that's easier said than done, and there are a large number of challenges that stand in our way as we try to address this issue of quantitatively fusing all this information, this disparate, heterogeneous information that resides across these scales and across these modalities. So what I actually have here is an instance in the context of the prostate of tissue specimens of an MRI and a protein expression profile. So what you've got here is actually a histological section of someone's prostate after it was removed. So this was someone who had a biopsy done. The biopsy turned out to be positive, and the recommendation of the urologist was to take the prostate out. So the prostate came out, and the prostate was then sectioned, and it was stained, and then viewed under a microscope. So what you're seeing here in pink is actually the digital image of a histological section of someone's prostate after it's come out. What you're seeing here is the same prostate that was imaged prior to resection. So before the prostate came out, an MRI was done, and that's the image of the prostate before it came out. Now, when we talk about fusing the disease-related information across modalities, we need to know where exactly the disease is on the imaging. If I want to fuse the patterns that I see on the histological level, and that's an example of what the disease looks like on the histology. This is zoomed in, and this is what a pathologist would see under the microscope. If I want to be able to fuse this information with what the radiologist is seeing on the imaging, well, I need to be able to align and correspond spatially the disease areas on the histology with the corresponding areas on the imaging. So what you've got here is actually the areas identified as being diseased, as being cancerous on the imaging. And this was done by aligning the histology with the in vivo MRI. So there are challenges in alignment. So before we talk about quantitatively fusing the information from different modalities, they have to first be aligned so that we know exactly where the diseased areas are on the various different modalities. That's one challenge. The second challenge is, well, we talk about quantitatively fusing this information because right now, pathologist looks at this data and says, well, this is Gleason grade 4 prostate cancer. The problem with that is that different pathologists tend to vary in their diagnosis, in their prognosis. Okay? So a pathologist who is looking at someone's prostate cancer, might say that this is really bad prostate cancer. But you flip it around and give it to another pathologist, that pathologist may say, well, this isn't that bad. Someone else might say, no, this is actually a great prostate cancer for this person to have. This is a good outcome prostate cancer. And yes, there is such a thing. There's good outcome prostate cancer and there is bad outcome prostate cancer. So one of the big challenges, in fact, with personalized medicine in the context of prostate cancer is actually to distinguish between the so-called tiger prostate cancers and the pussycat prostate cancers. The aggressive prostate cancers and the indolent prostate cancers. The prostate cancers that one will die with as opposed to on account of. Right? So one of the big challenges as we talk about quality of life is how do we distinguish the prostate cancer that won't kill you from the one that needs to be treated now. Right? So one of the challenges here is we can't rely on the subjectivity of the human interpretation because the subjectivity rises because of qualitative evaluation of the information. We need to be able to break this down into numbers. We need to break this down quantitatively. We need to convert these patterns into numbers that we can then start to use to analyze, to build classifiers, to be able to predict which ones are more aggressive, which cancers are more aggressive, and which ones aren't that aggressive. Right? So the next challenge is taking this information and converting it into a quantitative form. Right? So what does that mean in the context of histopathology? So one of the interesting things that pathologists use, one of the attributes that pathologists use to distinguish more aggressive or more virulent prostate cancer from more indolent prostate cancer is, for instance, the number of nuclei, the number of glands, the shape of the glands, the size of the glands. It turns out that we can actually go in and apply image analysis and machine learning algorithms to quantitatively analyze the morphology of glands, the size of the glands, the lumen within the glands, the number of nuclei. We can analyze spatially the distribution of the nuclei. We can analyze how the nuclei interact with each other. All this can be converted into quantitative information that we can then feed to a classifier to be able to predict or distinguish aggressive cancers from less aggressive cancers. Right? The third issue, one that is slightly more subtle, I think, is the issue of knowledge representation. So we're getting all this information from these various different sources, and here's an example of the alignment issue that's been resolved. So we've got the histology that's been mapped onto an in vivo MRI, so that's what you're seeing here. So even assuming that the knowledge alignment issue has been resolved, even assuming that the knowledge extraction, the quantitative knowledge extraction issue has been resolved, we're still left with the issue of knowledge representation and fusion. How do we take the information that resides in the MRI, which is just intensities, just pixel intensities? That's what a radiologist looks for. Radiologist looking at an MRI of someone's prostate is looking for hypo-intense regions, is looking for something that's dark. Okay? If you're looking at a T2 weighted MRI, looking for something that's dark. How do you resolve that? How do you fuse that piece of information with this very, very dense quantitative information that's coming about by arrangement of these nuclei and density of these nuclei? And in fact, the problem is even more acute when you talk about fusing information that's coming from protein expression data. So it's possible now to go into the prostate and take out little bits of tissue and use mass spectrometry techniques to look at protein expression. You can actually quantify the protein profiles. You can look at the expression of different proteins. So the question is, how do I resolve, or how do I fuse the information that's comprised of the expression of hundreds of different proteins with all this information that's coming from histology with essentially an intensity at a single pixel? Okay. So one of the big challenges when we talk about fusion is resolving this, the fact that all this information resides in different dimensionalities on different scales. Right? So one of the things that we've been trying to do in our lab is recognize the fact that, as I said, this data resides in very different dimensionalities. You've got a protein expression profile that's comprised of maybe 1,000 proteins. You've got a 1,000-dimensional vector. On the other hand, on the imaging, you might have a vector that's on histology, you might have a vector that's a few hundred dimensions. On the imaging, you've got maybe just a single pixel intensity. How do we resolve the fact that all these information reside in different scales, in different dimensionalities? So we've been developing, again, without going into the math, we've been developing techniques to address this issue by mapping this information into a different space. Again, without going into the math, essentially what we're doing is we're taking all this information, regardless or independent of its dimensionality, and mapping it into a new space. And in that new space, the differences in dimensionality, the differences in physical interpretation dissolve. And now, by mapping this data to this new space, you can actually start to do fusion in that new space. So what I want to show you over the next few slides are instances of how we're using image analysis techniques with these new fusion techniques to build better classifiers for detection and diagnosis and prognosis of breast and prostate cancer. I'm going to focus mostly on prostate, but maybe give you a couple of instances of our work in the context of breast cancer as well. Right? All right. So let's just start with computer-aided diagnosis from multi-protocol MRI. So for those not familiar with the current clinical paradigm for prostate cancer, essentially the workflow comprises of somebody having a very high PSA level. Prostate-specific antigen is a blood-based marker. Somebody with a very high PSA level is typically recommended for a biopsy. Patient goes in to get a biopsy, and this is what happens. A urologist goes in and randomly samples different parts of the prostate. That's what a urologist does. A urologist goes in and essentially samples between 12 to 24 times tissue from different parts of the prostate. And guess what? The urologist has no clue where the cancer is. The urologist is essentially just hoping that by inserting that needle multiple times in the prostate, he or she is going to be able to pick up disease if cancer is present in the prostate. Right? So there's no image-guided intervention here. There's no image-guided information that's allowing the urologist to figure out where to place that needle, how to optimally place that needle. Right? Now that tissue comes out, and that's analyzed by a pathologist, and the pathologist looks to find where the cancer is present. And if cancer is present, the pathologist renders what is called a grade. The grade of the cancer is a reflection of its invasiveness, of its aggressiveness. So higher grades reflect more aggressive, more invasive, more malignant cancer. Lower grades, on the other hand, represent more indolent forms of cancer. So that's the current workflow. Okay? So my group, myself and my clinical collaborators at the University of Pennsylvania, more recently Siemens and UCSF, as well as Beth Israel, have been working over the last few years to complement the current clinical workflow for diagnosis of prostate cancer by using MRI, rather multimodal, multispectral MRI, in conjunction with our image analysis techniques. So our hypothesis is that instead of a urologist randomly going and inserting this needle into the prostate in the hope that if cancer is present, he or she is going to pick it up, why not do an MRI before that biopsy? Take that image and then let our algorithms, let our computer programs run on that image, and let the program render an output like this. And this is a probabilistic output. It's a likelihood map that's generated by our program, where the high or the bright pixels in this image reflect a high probability of cancer presence as determined by our program. Okay? And you can imagine that something like this could serve as a very useful guide to a urologist to be able to go in and intelligently sample highly suspicious areas of the prostate, as opposed to randomly going in and sampling the prostate. Right? So that's really been our effort over the last few years. What we've also started to do over the last 3 or 4 years has been to use our computerized imaging technology in conjunction with the histology specimen. So the biopsy comes out. Now with digital pathology, with these whole slide digital scanners, you can actually place those glass slides with the tissue on them in these whole slide scanners. They actually work like your regular paper scanners or photographic scanners, with the difference that they render very high resolution images of these glass slides. And because they're digital images now, we can apply our computerized image analysis algorithms to essentially detect the disease extent on these digitized biopsy specimens. And not just that, we can also start to replicate the grading that the pathologist does in order to identify the invasiveness of the cancer. Right? So I talked about the fact that these different pieces of information reside in different dimensionalities. So even in the context of multispectral MRI, the different kinds of MRIs that one could do. So one could look at what is called T2-weighted imaging that looks simply at structural detail or textural information with regards to the disease. One could also do what is called spectroscopy. Okay, that's what I've got shown over here, which essentially reflects the metabolic profiles within the prostate. Okay, so a change, so essentially the MRI could be tuned to check whether there's been a drastic change in the ratios of choline and creatine, different metabolites. And if there is a change in the concentrations of these different metabolites, then that's highly indicative of the presence of some disease. Similarly, one can look at vascular imaging, what is called dynamic contrast enhanced MRI. And the thing with dynamic contrast enhanced MRI is it involves essentially injecting the patient with gadolinium or some contrast. And that contrast agent is then picked up by the tumor. And typically, the malignant tumors tend to be more profusely vascularized. They tend to have a larger concentration of blood vessels that feed into them. And hence, you can actually look at the changes in the intensities of the tumor as a function of time. So our hope and our efforts really have been directed towards using the information from these various different modalities, these MRI modalities, that's metabolic imaging, functional imaging, as well as structural imaging, in order to predict the precise location of cancer on the prostate. The question then is, well, how do you validate all this? So it's all well and good to say, this is where the cancer is, but one needs to be able to validate the efficacy of these algorithms. That's hugely critical when one is developing technology for cancer detection. So what we've been doing is we are currently involved in a study that's sponsored by the NIH. It's a 5-year study where we're looking at about 80 patients, all of whom are going to have surgical resection. So they're all patients who have been identified to have cancer on biopsy. They've been determined, they've been scheduled to get a radical prostatectomy done, so the prostate's going to come out. Before the prostate comes out, they get an in vivo MRI done. The prostate comes out, and then we actually do the alignment that I talked about. We do the registration between the histology and the MRI in order to map the disease extent from the histology onto the MRI so that we know exactly where the true location of the disease is on the MRI. And why that's useful? Well, it's useful because we can now start to train our classifiers, we can train our system, and we can also quantitatively evaluate the efficacy of our classifiers on a per pixel basis. Right? So there are several challenges, and I'm going to probably skip over some of these things in the interest of time. But there, along the way, along with determination of the disease extent, the cancer extent on the MRI, there are other things that we need to know. For one thing, you need to know where the prostate is. So if you take an MRI of someone's prostate, the capsule of the prostate is located only in a very small part of the image. So the first challenge is how do we actually identify exactly where the prostate is? So we've been developing segmentation tools in conjunction with the metabolic data, in conjunction with the spectroscopic data, to precisely and automatically identify the boundaries of the prostate. And this is huge. So this is the first challenge. Before we can start to talk about the presence of disease within the capsule, we need to know where the gland capsule is. So we've been developing these techniques that are able to go in an automated fashion, identify exactly where the capsule is, and having identified where the capsule is, we can now start to estimate the volume of the prostate very precisely. Okay, so what you're seeing here is an instance of our recent work where we're able to segment out the prostate and then quantitatively and automatically identify the volume of the prostate. And this is huge, especially in the context of treatment, because the volume of the prostate is a hugely important marker in evaluating the efficacy of prostate cancer treatment. And one needs to be able to do this very quantitatively and very reproducibly. So one of the advantages here is that these methods could be applied to evaluate quantitatively the effect of a particular therapeutic regimen. All right. So I talked about this. I'm not going to talk about it in any great detail. Like I said, we've got to be able to evaluate how good our algorithms are in a quantitative fashion using histology. Like I said, we're looking at a cohort of patients for whom cancer was found on biopsy. Prostate was removed. What you're seeing there in pink is the histological section. This is the section of the gland that was obtained after surgery. What you're seeing in gray reflects the MRI that was taken before the prostate came out. What you're seeing here are the algorithms we've been developing to automatically align the histology with the MRI. And the reason, like I said, we need to align the histology with the MRI is because we want to map the spatial extent of disease from the histology onto the MRI. Because on the histology, when we do the staining and the pathologist looks at it, that's really the definitive source or the ground truth, as one might call it, of where the cancer extent is. The histology provides us with the true location of the disease because one can microscopically analyze that histological specimen. So a pathologist can go in and delineate exactly where the tumor is on the histology. On the MRI, well, we don't know because we don't exactly have that level or that density of information that's available on the histology. So hence, we need to map the ground truth data from the histology onto the MRI. Okay, so what you're seeing there are the methods we've been developing in order to allow or facilitate for this alignment between the imaging and the histology. We've been developing these classifiers using these different modalities on MRI. Here's an instance of our classifier working on T2-weighted MRI. Again, the image that you see here is similar to the one I showed a couple of slides ago, where the bright areas represent regions identified as highly suspicious by our pattern recognition program, our computerized image analysis program. And what you're seeing here is the mapping of the tumor from the histology onto the MRI. So what this is providing is providing the ground truth. So you can use this, you look at this, and you say, well, okay, this is a pretty good match. It may not be perfect, but it's a pretty good match. And guess what? I don't need to be perfect because, again, the urologist is going in and randomly sampling different parts of the prostate. Hey, if I can give even 5% added information to the urologist in order to improve his or her biopsy, well, that's something. I think we're doing a lot better than 5% here. Right? So this is just using T2-weighted information, just looking at structural information, structural textural patterns of the disease. That's what T2-weighted MRI is all about. And we can do better. We can do better by looking at dynamic contrast enhanced MRI, where I said it involves inserting a contrast agent like gadolinium into the prostate and then imaging the prostate as a function of time. So we've been applying different methods, spectral clustering methods for the analysis of DCE MRI, and similarly, like T2-weighted MRI, we've managed to get very, very good results, quantitative results, which show that we can get upwards of 80% sensitivity and specificity on a per pixel basis. And this is important. When I talk about the evaluation of the performance of our classifiers, I'm talking about it on a per pixel basis, on a per voxel basis, because we can do that sort of detailed quantitative evaluation because we can align the histology with the MRI. So that's just with T2-weighted MRI. Similarly, again, we've developed these techniques for magnetic resonance spectroscopy as well. I'm looking at the clock and I'm running out of time, so I'm going to move things along a little quickly. We've developed these methods for analysis of magnetic resonance spectroscopy as well. Again, what we found is we're able to do very well by looking at changes in the concentrations of different metabolites, and we're able to leverage that information to identify disease extent in vivo. But so far, we've looked at all these modalities independently, and I talked about our sort of big push towards fusion of this information. I talked about how the real sort of quantum leap is going to happen by the quantitative fusion of the various kinds of modalities of data that are available to us. So we've been looking at the fusion of T2-weighted imaging with spectroscopy recently, and what you've got here are ROC curves. Essentially, it's just a fancy way of saying that it's a performance measure that allows you to quantitatively evaluate the performance of these classifiers. And really, the take-home message here is the black curve. The black curve is the fusion of the spectroscopic data along with the T2-weighted data. And you can see that the performance is better when you fuse the two pieces of information because this area, the area under this curve, is much larger than the area under these two individual curves. So essentially, fusing the two modalities results in better classifier performance than the individual modalities themselves. Similarly, we've looked at fusion of T2-weighted imaging with dynamic contrast imaging. Again, we've seen similar trends where the curve has a higher area by fusing the different modalities. And again, all this is evaluated in a very, very quantitative per pixel or per voxel basis. Okay? We're able to do this because we're able to map the disease extent from the histology onto the imaging. More recently, we're about to start a project with Riverside Technology up in New York and Beth Israel Deaconess Medical Center on fusing MRI and ultrasound for prostate. So ultrasound, while it doesn't have the resolution that MRI has, certainly has certain benefits because it provides different kinds of information. It provides acoustic information. It provides RF data. So one of the projects that we're waiting to hear on from the NIH is again a very large multi-center 5-year R01 grant, which, if it comes through, will allow us to actually fuse MRI with ultrasound in order to build better predictors for disease extent for prostate cancer. All right, so I've talked about diagnosis so far. Let me talk a little bit and about our work in prognosis. So looking at histopathology and developing or applying these algorithms in the context of histopathology to distinguish the good outcome tumors from the bad outcome tumors. So this is the grading system that I mentioned that pathologists use, which is the Gleason grading system. And all the tumors really get mapped into a 5-point scale. This was developed by Dr. Gleason back in the 60s, and it's testimony to the robustness of the grading scheme that has survived 40 years, or actually 50 years now. Unfortunately, Dr. Gleason passed away last year, but he's really left quite a legacy because while for other diseases like breast cancer, there have been multiple grading systems that have evolved, Gleason grading is still the de facto universal scheme for evaluating the invasiveness of prostate cancer on histopathology. So like I said, essentially the low numbers there, 1 and 2, reflect good outcome tumors, and if a tumor, prostate cancer, is identified as 1 or 2, then that's a good thing, because that reflects indolent disease. That reflects disease that's probably not, that's going to do well. That's probably something that is not going to kill you. Okay? On the other hand, 4 and 5 represent invasive tumors. Those represent very invasive, aggressive, malignant tumors. Okay? So the problem is, however, that pathologists have a tough time distinguishing between the grade 3 and the grade 4, the intermediate grades, because of the similarity in the morphological characteristics between the grade 3 and the grade 4, there's a great deal of variability between experts. So they're able to do a great job distinguishing the 1 from the 5. In fact, it's interesting that my graduate student who's been working on this project for the last 4 years has actually looked at so many of these. He does a great job distinguishing the 1s and the 2s from the 4s and the 5s. Okay? So that's not the issue. The issue is how do we distinguish the 3s from the 4s? And it's important to do this because the ability to distinguish the 3s from the 4s in turn has implications for treatment. We need to be able to really bin these tumors appropriately, because our ability to do that is then going to decide what treatment strategy we're going to apply to these patients. So we've been developing quantitative image analysis techniques in order to look at the patterns within the histology specimens, within the biopsy specimens. We're looking at a number of image features which are all derived automatically using computer algorithms. We look at morphology of the glands. That's the shape of the glands, the size of the glands, and we build classifiers using these features to be able to distinguish the different grades of prostate cancer. And actually, as you can see here, we're doing a very good job. These are results that we're presenting actually in a conference in Rotterdam next week. So this is really hot off the press. And you can actually see that we're able to distinguish the intermediate grades of cancer, the Gleason grade 3s from the Gleason grade 4s, with a fairly high accuracy, with in fact over 80% accuracy. And that's pretty good. There are other features we've been looking at. I'm going to skip over this. We're looking at distribution and spatial arrangement of nuclei and other histological structures. But really the key message here is that there are descriptors that essentially yield quantitative information from these biopsy specimens. So you can actually go in and apply these descriptors to mine or to really translate the qualitative visual information that the pathologists see into numbers. And those numbers, which supplied to a classification or machine learning scheme, allows us to reproduce what they do in a quantitative fashion, but in a far more reproducible fashion. So that's just an example where, that's another example where using some of these spatial features, again, we're able to distinguish between Gleason grades 3 and 4 with a high degree of accuracy. All right, so this is an example now from the breast. This is something that I'm extremely excited about. This, again, is work in progress. But we've been looking at a cohort of breast cancers. ER-positive breast cancers or estrogen receptor-positive breast cancers are the most common type of breast cancers in the United States. There are about 200,000 new cases of breast cancer every year, and of those, about 60%, about 120,000 of them tend to be ER-positive or estrogen receptor-positive breast cancers. Now, all these women are going to be treated, well, in the United States, most of these women, if not all of them, will be treated with tamoxifen. Okay, so tamoxifen is a drug that's used to treat women with ER-positive breast cancer. That's the first line of defense. However, most of these women also end up getting chemotherapy. And chemotherapy, of course, is expensive, but it's also deleterious in terms of its side effects. Now, here's what's really interesting. It turns out that tamoxifen actually does very well on women who have good prognosis ER-positive breast tumors. So nearly 40 to 50% of that cohort of 120,000 women are going to respond favorably to tamoxifen. In other words, about 40 to 50,000 women who have ER-positive breast cancer in the United States do not need additional chemotherapy. Tamoxifen alone is enough. The problem right now is we don't know how to distinguish women who are going to do well with tamoxifen alone versus women who need additional chemotherapy. If we did know that, then we could be sparing 40 to 50,000 women every year expensive and traumatic chemotherapy. So it turns out about 5 years ago that a company named Genomic Health came out with a molecular assay. It's a gene expression based assay that costs about $4,000 a pop. So the idea was that if you got a little piece of this tissue specimen, you could then analyze it for the genes, and based on the expression of the genes, you can make a prediction about the outcome of this breast tumor. That's $4,000. What we have found, however, is that our image analysis algorithms are able to look at these ER-positive breast tumors and actually are able to separate out the good outcome tumors from the bad outcome tumors. And in fact, what we found in a small cohort of patients is that we're able to do almost as well, and it's a small cohort, we're able to do almost as well as Oncotype DX. So what that means is that potentially we could apply our image analysis algorithms to the digital images of the tissue samples and really do this for next to nothing. And what is really exciting is we could start to use this technology, because it's a software, because it's a program. We could basically upload this to a web portal, and we could have people in India, in China, in Africa essentially upload images, digitized images of the biopsy samples, and start to do the analysis, make a prediction of outcome remotely. These are people who cannot afford $4,000 in order to analyze that breast biopsy specimen. So this is really, really exciting work that we've been involved in over the last year or so. We call it IBRIS, Image-Based Risk Score, where the idea is that there are patterns predicting outcome for the disease that are present in the histology itself. And our ability to quantitatively mine that information will tell us the prognostic outcome, or give us a prognostic prediction for these patients in a manner very similar to this more expensive molecular assay. Lastly, this is the last but one slide. We've also been applying this technology to looking at breast MRI. The breast MRI, as several of you may know, has become sort of the de facto adjunct to mammography for screening of women, screening and staging of women for breast cancer. So it's a great technology. The problem with MRI, of course, is that it has a very high false positive rate, so it tends to pick up everything. And we've been developing technology to, A, improve the specificity and sensitivity of MRI, but what we've also started to do is to be able to apply these image analysis techniques in conjunction with DC MRI to see whether we can distinguish more aggressive from less aggressive breast cancers on the MRI. The previous technology I talked about was after the biopsy had been done. I'm talking pre-biopsy now. So imagine if we could identify the more aggressive tumors on breast MRI before the biopsy had been done. And again, just to think about the numbers, I mean, 200,000 women are diagnosed with breast cancer every year. Again, some of those women have more aggressive kinds of breast cancer. The most aggressive breast cancer that we know of today is the so-called triple negative breast cancer. Okay, so it's ER negative, PR negative, and HER2 negative. Most aggressive kind of breast cancer there is. So our ability, we need technology like this that we can look at the MRI of the woman and be able to predict whether this is a more aggressive or less aggressive breast cancer. And we've got some very, very exciting data that appears to suggest that our technology can actually start to distinguish the more aggressive tumors from the less aggressive tumors on the MRI alone. So we're actually presenting this work in a conference in Stockholm in the early part of May. And then finally, I just want to end with the applications of this technology to therapy, to directing therapy. So I talked about this for prostate, where radiation therapy, which is a very popular form of therapy for prostate, has the caveat that very often unnecessary radiation is given to areas outside the prostate. In fact, it's one of the reasons that some bladder cancers develop, and rectal bleeding and rectal cancers as well. So the idea is, if we know exactly, if we can segment out where the prostate is, and we can apply our image analysis algorithms to identify specific areas in the prostate that are cancerous, then could we start to direct high-dose radiation to those specific areas alone? So the area in red that I've delineated on the panel to the lower right represents the area identified by our system as being cancerous. So the ability to now have that information allows an oncologist, a radiation oncologist, to be able to specifically hone in and give high doses of radiation to those specific areas while sparing areas extraneous and also perhaps giving slightly lower dosage of radiation to the other areas. So again, with skipping some of the technical details, this is really what the dose plans look like. So these are the updated dose plans. This is done by a dosimetrist. This is what is used by an oncologist to direct the radiation. And we've started to develop these modified dose plans. This is again done with the folks at the University of Pennsylvania who use the maps, the cancer maps that our algorithms identified and came up with updated dose plans. Okay? So that's only half the story. Clearly, where we need to go with this is to start to do a clinical trial. So we need to be able to take this technology and start to apply it to a cohort of patients who are going to be treated with radiation therapy for prostate cancer, and then to compare it with another cohort of patients who don't get this technology, or who just get radiation the way it's currently done in the clinic. And at the end of the day, the real proof of the pudding is going to be in terms of outcome. So we're going to know when we complete this clinical trial, hopefully, the differences in outcome will be obvious for the two different cohorts. And that at the end of the day is really going to be the proof of the pudding, and we hope to get there soon enough. So it looks like I'm almost done with my 1 hour. So I just want to sort of sum up and look to the future. Like I said, I think one of the challenges going forward as we sort of chase the holy grail of personalized medicine is going to be our ability to quantitatively fuse information from different modalities, from different scales. And I think there's several challenges that still remain. And what I've tried to show to you are some of our own humble attempts at trying to address some of these huge challenges. These are by no means done. I think there's several different challenges that remain. And of course, we're looking just at a couple of diseases, but one can imagine applying this paradigm and this framework to other diseases as well. So though much abides, I think there's certainly a lot to look forward to. But at the end of the day, along with all the imaging data and gene expression data and histological data that's becoming available, I just want to sort of restate the fact that quantitation and the role of computerized analysis is going to be a key element of our quest for this holy grail of personalized medicine. Okay. So without further ado, I'd like to just acknowledge the various funding agencies that were responsible for this work, and thank you. Yeah.
Where does PET scanning technology fit in, particularly with diagnosis of post-surgical recurrence?
Absolutely. I think PET is certainly an extremely important adjunct to imaging. So I talked about some of the different modalities in the context of MRI. We are looking, we haven't started this yet, but we hope to be able to look at MRI in conjunction with PET for women with breast cancer. And certainly both in the diagnostic setting as well as in the post-therapeutic setting for evaluation of therapy and response to therapy, I think PET is certainly going to play an important role. Yes?
Yeah, I was kind of curious about validating your methodology for distinguishing between grade 3 and grade 4, at least I think it was. So if you have a computerized system and yet the gold standard never agrees with each other, how do you come up with a
I was hoping nobody would pick up on that. Excellent question, and fortunately, I like to think that we've been privy to work with some of the top prostate pathologists in the country, in fact. So the collaborators on this project are Michael Feldman and John Tomaszewski, who are actually top-notch prostate pathologists. John Tomaszewski is the chair of pathology at the University of Pennsylvania. But certainly, I think we'd like to, we typically have used only those studies that have been labeled as grade 3, where there's a consensus between these two experts. But certainly, that is an issue. I mean, how do you establish gold standard? I mean, sort of a chicken and egg sort of issue. But at the end of the day, Gleason grade is really a surrogate. I mean, at the end of the day, Gleason came up with this paradigm to categorize these tumors into grades 1, 2, 3, and 4, and 5. But at the end of the day, is that really important? At the end of the day, it's really about patient outcome. At the end of the day, it's how is this patient going to do? And I think where we're trying to get to is getting beyond Gleason, is getting beyond grade, to getting to the point where we can predict the patients who are going to do well versus the ones that are not going to do well. The ones who are going to have recurrence versus the ones who are not going to have recurrence. So I think where this technology is headed is really in clinical trials, in prospective clinical trials, where we make a prediction and then we look at the outcomes. We figure out how well we do. Because I think really that's what it's all about. Yes?
Are there any new imaging technologies on the horizon?
Absolutely. There's several imaging technologies coming up all the time. There's a lot going on in terms of optical imaging, some very, very promising optical imaging and light imaging technologies. There are caveats with some of the optical imaging technologies in the sense that they don't really have the ability to go very deep. So, in terms of in vivo imaging, you need the ability to really be able to go deep into the system to be able to get to the organ that you're interested in studying. But certainly there have been advances both in spectroscopy as well as in optical imaging. None of it is quite translational yet. So none of it is at the point where it could be taken into the clinic. But certainly there's a lot happening. So I think, like the African proverb goes or the Chinese proverb goes, I think if you're an imaging scientist, we're certainly living in very, very interesting times. Yes? Yes? Yeah.
Have you done any animal studies to determine how good your model is?
Yeah. So we've been lucky that, we've been looking at these prostatectomy specimens. So in the context of prostate, we're looking at this cohort of patients where we've been able to take the prostate out and then study it ex vivo. So in that sense, we haven't really needed animal models. My interest has really been in looking at clinical data and just working with human data. But certainly this framework could be applied in the context of animals. We haven't gotten there yet because, like I said, we've been fortunate to have histological data by means of which we could do this quantitative validation. Yeah.
If you know where the cancer is, and based on that data, you constructed your model, then you cannot apply that to the next step. So what I'm saying is that if you use this data, after removal, you identify it and you calibrated your model, then you have to apply it in independence of the data.
Absolutely. Absolutely.
Based on that patient or an animal, live animal, beforehand, to see where it is, and then open up the animal and find out whether the model.
Right. Or you could Or you could take the approach we're taking, which is basically building our model based on data that's coming from one institution and looking at, so in fact now we're getting data from UCSF where they're doing the same thing. So they do radical prostatectomy for patients who've been identified with prostate cancer, do the in vivo imaging, and we use that data again quantitatively. So we built our model using data from Penn, but we do independent evaluation on this cohort from UCSF. So that provides us with an independent cohort of data, again, where we've got histological data as well as imaging data. So that's an independent cohort that we don't use for training or fine-tuning of our model. Yeah?
When do you think these techniques will be used in routine practice?
Very good question. We're hoping soon. So some of the things that I talked about, for instance, the MRI for the prostate and ultrasound and MRI fusion, these are both projects that we've just begun. And the ultimate goal of these projects over the next 5 years is actually to start to migrate, to refine the technologies to the point where we can go to a clinical trial. And I think that's really our real goal. We want to be able to refine this technology, take it to a clinical trial. Once we do the clinical trial, then we're ripe to take this technology into the clinic. So I'd like to think in the sort of next 10-year time frame is when we'd really be able to like to take this technology and start applying it, basically give it to the clinicians and have them run with it. Yes?
Are any parts of this being used now? Are they doing MRI and these supplement what in actual practice in hospitals now?
So for the prostate, currently MRI is not used in screening mode for the prostate. It's being used in staging mode. So that is, it is used to image patients who have documented prostate cancer. But the hope is that if we can generate enough papers and data that makes a convincing argument, that enough people are going to be able to buy in, and we're going to be able to move this into the clinic. And but that's in the prostate. In terms of the breast, some of this stuff is pretty much ready to go. So some of the data I showed with the breast MRI, we could actually start to use tomorrow. We, in fact, are considering, we've been talking about trying to license some of this technology. Some of the technology, in fact, the Gleason grading has already been licensed to a company. So that's going to go into commercial scanners to be able to predict outcome. So some of it is, the MRI is still going to take some time. Some of the other technology is going to get there soon. Some of it is already in the commercial pipeline. Yes?
I find your research very exciting, but I have a comment or a question to raise as a physician myself. And it relates to one of your earliest slides where you postulated that the breast biopsy might be worth $5,000 on average, and perhaps by finding a technology that can reassure both the physician and the patient that a biopsy is not necessary, I think is unrealistic in many regards. I think what will happen is that if a highly suspicious lesion is either felt by a physician or patient or is seen on a screening mammogram or MRI, that in our society there's going to be the move by the patient to want to know for sure, even if there's a 90% certainty, that I don't think that what we're going to do is save many millions of dollars. In fact, I'm afraid that this is just going to be one extra added expensive technology which will be added on to the cost of the biopsy.
Yeah, so I didn't certainly mean to suggest that suddenly we're going to cut down the total, we're suddenly going to halve the number of biopsies. I certainly don't think that's going to happen. But very often what may happen is, again, just like with the Gleason grading scheme, we've got the BI-RADS grading scheme for MRI. And the idea is you've got, again, sort of these 5 compartments that you lump a lesion into. So a radiologist looks at the lesion, looks at the morphology, looks at the texture, and says that this is BI-RADS 1 or BI-RADS 2, BI-RADS 3, BI-RADS 4, BI-RADS 5. If it's a BI-RADS 1 or 2, 1 is essentially a lesion that is definitely benign. A BI-RADS 2 is something that is almost 90% benign. So that's really what I'm talking about, where you're in that sort of threshold where you're almost certainly, you're almost 100% confident, but the ability to have a second reader, okay, might allow you to partially cut down on some of those unnecessary biopsies. But certainly, I think something that looks remotely suspicious should and will be sent to biopsy, no doubt about that. But I'm talking about sort of the low-hanging fruit where due to exhaustion, okay, just due to a radiologist staring at the screen for 12 hours, 14 hours, is sometimes mistakes occur. And something that might have been read as 100% benign the next morning is sent off as sort of indeterminate the previous evening after having read scans for 14 hours. I think that's really where some of the technology, because this stuff doesn't tire, it can keep going. And I think that's probably the sort of the target that I was sort of alluding to. Yes? The DoD? The DoD has been supporting over the last 15 years or so, they've been supporting research in prostate cancer, breast cancer, ovarian cancer. They've been supporting, obviously, the VAs. And most of this has been mandated from the Congress. This is funding from a special program called the CDMRP, that's congressionally directed medical research funding. They've been putting aside about $80 million a year for prostate cancer research and about $100 million a year for breast cancer research. This is, the numbers have sort of been roughly the same. Unfortunately, they haven't been increasing, but it is what it is. So we're thankful for that.
Let's thank Dr.